Welcome to the Strive podcast, where we embark on a captivating journey through the realms of mind, medicine, and motivation. I'm Simon Mundham, your host, and today I'm honored to be joined by Ed Gaines, healthcare attorney, regulatory strategist, and one of the most influential figures shaping how medicine is actually paid for and practiced in the United States. He's the Vice President of Regulatory Affairs and Industry Liaison at Zotec Partners, LLC, the largest privately held physician and hospital revenue cycle and practice management services company in the U.S. He advises Zotec clients across their hospital-based and multi-specialty practice settings on healthcare regulatory issues, including reimbursement policy, out-of-network federal and state laws, Medicare and Medicaid programs, health plan payer issues, advocacy, and the federal No Surprises Act. He serves as industry liaison to physician specialty societies and industry trade organizations across Zotec's client base. With over 31 years of professional healthcare experience with Zotec and the combined entities, Ed brings unparalleled depth of knowledge and experience to his role at Zotec. Since 2008, he's been a member of the American College of Emergency Physicians Reimbursement Committee, where he chairs Work Group 2, focusing on the NSA, OON, and bad payer issues. Don't forget to like, follow, and share this episode to stay connected with the conversations we bring you. For more updates and exclusive content, follow us on Instagram or X at strive_podcast and on TikTok at SimonOfficial. Join our community and be a part of the journey to explore mind, medicine, and motivation. Thank you so much for coming on the Strive podcast. I'm really excited to be talking with you today. I think our guests will have a lot of information that they learn from speaking to someone on the law aspect of it, figuring out the medical legal aspects of practicing medicine.
Well, thank you, Si, for having me and looking forward to the discussion.
Definitely. Just to start off, you've spent decades inside reimbursement and coding education. What pulled you into this side of healthcare?
Well, I got started with a large physician group that was staffing emergency departments, anesthesia, and radiology all over the country. They were doing acquisitions. They needed help in their revenue cycle company. So they asked me to help out there. I became the general counsel of the revenue cycle company. So I spent my first 15 years of my career really focused just on emergency medicine, a little bit with anesthesia and radiology, and then through some acquisitions. That company was acquired in 2008 by a subsidiary of CBiz, which is a publicly traded professional services firm. We expanded into radiology even further and other specialties. And then we were acquired by Zotec Partners in 2013. So I took on additional responsibilities for that group of specialties. Those specialties represent the majority of the specialties that we work with, but not all of them. We work with orthopedics and multi-specialty groups that are hospital employed and that kind of thing. So ambulatory surgical centers as well. About 24,000 physicians we support in all 50 states. So I was interested in the reimbursement aspects of it. I helped form a trade association, Emergency Department Practice Management Association. It'll be 30 years next year, and our anniversary. In 2 weeks, I will celebrate my 32nd anniversary working in the field. So it's been a real journey where I learned a tremendous amount from many of the volunteers within those national specialty societies. Continue to learn a lot, and then eventually was in a leadership position both with the trade association I helped form and with ACEP, which is the American College of Emergency Physicians. So and that's how I got kind of tagged to out of network balance billing about 15 years ago. Around about may have been 2007, 2008, the California Supreme Court got active in terms of out-of-network balance billing specific to emergency medicine. And then you saw kind of a blossoming of states, New York, Texas, various Florida, got into regulating the out-of-network balance billing situation. And then, of course, the NSA came along in the 2018, 2019 timeframe. So that's kind of what it was. It was in a way kind of a very, winding path to get there, as often is the case. But I I had an interest in it, and I spent a lot of time doing it. And fortunately for me, Zotec Partners and the predecessor companies that I was part of supported all of my work. And it's, as you can imagine, it's hundreds of hours of volunteer work with these organizations. I chair the NSA task force for EDPMA. We have 30 plus volunteers on it. We meet 4 to 6 times a month. We produce comment letters. We engage with the agency in Zoom meetings, in-person meetings. We provide feedback. We give them the data that they're looking for in terms of, what's happening out in the field. So those things have all been very rewarding, and I think they've helped move the needle favorably. I'd like to think that. I think it's true objectively, but it's it's a continual process. I learn things every day from our doctors, from our coders, from my colleagues who are in client services and advocacy, and that's the part that really got me probably most interested, was when we got involved in advocacy back in the mid 90s.
Definitely. And thank you so much for all the stuff that you do to make
Sure.
physician jobs easier as well. And it's quite interesting. Our clinical training does not really teach us about the business or legal aspects of providing care. It's just about very, textbook algorithmic ways to take care of people, but not all the forces influencing all the dynamics involved, right? And I'm in my business school training right now. And from like a reimbursement perspective, like I didn't know what, like, the differences between fee for service or value based payment or capitation until I came to my business school. And, it's a disservice to us as like a field. I feel like that it's not part of our curriculum. Um, and it's so misunderstood, broadly speaking, I feel like. And so at a high level, why is reimbursement still so misunderstood by physicians?
Well, I think you're right. I think it is for many specialties. It's not part of the education. It's not part of your residency training. ASEP has made some real major steps to address that. They've developed an entire online course on reimbursement and coding for folks in residency. Because in some residencies they'll do some training and education around it, and some they don't do any whatsoever. So those docs that come out of the residency programs with no training, one of the first things our client physicians do is they say, please take these newbie doctors and teach them the real world of what it means to document, and what impact their documentation has on their coding, on their RVU generation, and all of those things. So um, it, I think it's something that we could all shine a bigger spotlight on as a need within the physician community writ large. Because if I walked up to probably 9 out of 10 of the doctors who attend, an ASEP meeting, the anesthesia meeting, the radiology meeting, and I said, do you know who's on your RUC team? They would probably look at me and say, what's a RUC, right? And even though the folks that are on that team representing your specialty may be part of a decision to literally move not millions or tens of millions, billions of dollars within the Medicare, Medicaid system, right? Because their recommendations are, generally speaking, over 75% of the time taken by CMS. So it's critically important, especially for your generation, to understand how and why you're paid. But unfortunately, many do not know. Within our trade association, we've started an emerging leaders program to really help not only the clinicians, but the folks that do revenue cycle management like we do, or consulting, to really learn the other side of it, right? So the doctors explain some of the aspects of being a medical director and having residents and documentation and those types of things. And the revenue cycle folks try to teach those new physicians what it means to document and what their coding and reimbursement ultimately can do. So I think it's a service, certainly, that you're doing a podcast like this, and I think it's something that we need to kind of, shout from the mountaintops and say everybody should be exposed to some degree of this. And I know in ASAP's case, they tried to make it very easy so that folks could do it on their own pace. They could pull up basically a recorded webinar. They could get printed materials if they wanted them. They had mentors that they could reach out to, that kind of thing. So I think it's it's critically important.
Definitely. And, like as I keep learning through all of this, right, the last 20 years of legislation make me very furious at times, but also
Right.
hopeful at times. And I think this is a good segue to talk about the No Surprises Act itself, which is quite prominently influential in a lot of things that, in terms of practicing medicine for physicians. In lay terms, what was the No Surprises Act trying to fix?
So the problem it was solving for was, number one, protecting the patient. And from the beginning, the physician community was completely unified to say the patient needs to be protected from out-of-network balance bills. The health plans argued that no, that's not really true. The physician community wants to retain the right to balance bill, and we said no. What we want is fair payment, and we want a mechanism, if we don't think we're being fairly paid, to go achieve fair payment. So point number one was patient protection. Point number two was, how do you resolve once the patient's removed? Because the patient pays their in-network cost sharing, and you could win 50x of Medicare in an independent dispute resolution with the health plan and the patient. So the hospitals took a deep sigh when they knew that the patients would be protected from the balance bills. But what the health plans were pushing very hard in Congress and came very close to passing was what we call a benchmark bill. And it would have benchmarked your reimbursement to either Medicare rates or an allowed amount that they calculated. And then there would have been no dispute resolution or IDR process. And IDR is, by definition, an independent process by which you can bring a claim and say, I think the initial payment made by the plan was not a fair payment. And according to statutory factors in the NSA, here's why I think that's not a fair payment: the acuity of the patient, prior contract rates, the specialty of the physician, was it a trauma center? All of those types of factors come in along with other data. So that was the thing that we fought hard for and were able in the end to get, in part because we had a sterling example of what we didn't want, which was California. That was AB 72. Mark your specialty and all non-emergency specialties to 125% of Medicare, full stop, with a very dysfunctional IDR process. And then we had New York and Texas. New York has probably the oldest IDR process. Texas probably has the most, I would say, effective state IDR process. So we had Kevin Brady, who was the minority leader on the Ways and Means Committee from Texas. So his constituents were familiar with the Texas process. He was familiar with the Texas process. So that was the concept that we pushed and were able to get. And then, we started with a set of rules that the prior administration passed that were, according to not only a district court federal judge, but an appellate court of federal judges, contrary to the very statute. And so it took several years of litigation to have those rules overturned and then rewritten. And curiously, CMS, or one of the agencies, it may not have been CMS, but one of the agencies estimated in the first year of IDR in 2022, there would be approximately 17,000 cases. Even though in Texas in 2021, the prior year, there are almost 50,000 cases filed in just one state. So what happened, Cy, as a result, was it was under-resourced from the get-go, right? Because they underestimated what the demand would be. And then you have the litigation on top of that because the rules were written, as the judge said so famously in one of his opinions, it was clear to him that HHS had tried to put their thumb on the scale of justice in favor of the health plans. And that's not what the statute said. The statute was very clear about what factors needed to go into the decision making. So, so it's been a long flight, but a fight, but a great exercise in physician advocacy. And I can't overstate the importance of the physician community speaking with one voice, because the biggest complaint that you hear in Congress when you go with a physician to Congress is you all are not on the same page, right? There's disagreement within the House of Medicine, but we were unified. We were unified on the patient protection. We were unified on the need for the independent dispute resolution process. And there was no daylight between the major medical specialties, the AMA, the Hospital Association. So that's, I think, why we ultimately won that battle. And it's truly David and Goliath. I mean, the health plans had a horrible 2025. You're in business school right now. I just put this on X, I think, this morning. The top 5 or 6 health plans threw off $26 billion in profit. And that's probably their worst year in 10 years. And UHC was half of that, almost. It was over 12 billion. So I've said this so many times until I'm blue in the face. There's plenty of money in the healthcare system. It's just misdirected out of and away from those of you who provide care as physicians and hospitals. So that's in part what the NSA does, is it forces the plans to have to go to an independent third party who has to file a conflict of interest disclosure, and they decide what fair payment is. And that part they don't like, because prior to that time, for decades, there was only one decider in what the payment amount was, and that was the health plan. It was either in your contract, whatever your contract said, or it was an out-of-network allowed amount that they determined, and then, if you balance billed the patient, you balance billed the patient or not, and, that was that.
Definitely. And, as I go through my training, like one thing I'm very worried about is my autonomy as I get through, my career, right? Will I be able to take care of patients without a plan telling me I should or shouldn't provision certain services, or I am utilizing too much, and so I have to have prior authorizations for different aspects of the care I provide, especially with these vertically integrated systems, right? Like whether it's the PBMs, health plans, even on the provider end, right? There's many big players or monopolization of players with that vertical integration that control that whole continuum. And a lot of their mantra is delay, deny, down code, right? And when we talk about these problematic payer practices, right, what would you say are the top 2 or 3 tactics physicians should understand or be more aware of?
I think you nailed it, Sai. It's prior authorization has been weaponized, no question about it. Interesting that the CEOs of the major health plans testified to Congress a few weeks ago and essentially said, "Oh no, we don't engage in nefarious prior authorization practices." And I'm falling out of my chair laughing because I remember the day when prior authorization was required in the emergency department. If you woke up at 2:00 in the morning, you were supposed to call and ask a nurse line and say, "Here are my symptoms. Can I go to the ED? And by the way, I need that special authorization number or my claim won't be paid." Believe it or not. Then we passed the prudent layperson laws that said, if I'm a prudent layperson and I wake up in the middle of the night, I think I'm having an emergency, the plan has to pay, and I am entitled to coverage, right? Because the doctors under EMTALA have to treat me. So I think it's the denial aspects, Sai, have just ratcheted up higher and higher every year. And it seems like it is at a level that I haven't seen in my 3 decades. And I don't know if that's AI generated as much or, software developed or a combination thereof. But at the end of the day, it's all a black box, right? I mean, I've been on calls with major health plans who have said, we use a third party. We can't tell you who the third party is. We can't tell you how their edits are written or how they're calculated to adjudicate claims. I mean, it's a little bit like, are you kidding me? I mean, so we're subject to a black box process until such time as you deem it that it's no longer necessary because we meet some profile that you have based on some standard that you won't disclose to us. I mean, it's incredible, the lack of transparency that we deal with. But what's happening is, because of the NSA, in part, I think, Cy, is groups are saying, look, to the health plans, if you don't stop engaging in the denial, the downcode, and the delays, then we're going to terminate the contract, and we're going to go into this IDR process. You're going to pay us an out-of-network, an initial allowed amount, a QPA, qualifying payment amount, but then we're just going to take the battle over payment into the IDR process. And so groups are leaving network contracts not as much sometimes over the rates as they are the claim adjudication practices. So the NSA, and I don't think this was ever really intended per se by the designers of the NSA, but I don't think they also had any idea what kind of denial activity they were going to see from the health plans that we're seeing right now. So as a result, the NSA has become kind of a tool, if you will. It's like, okay, if they won't listen to me when I try to get them on the phone or communicate with them about the edits and the denials and, what does the black box look like? What kind of transparency can I get? If I can't get that, then I'm out. I'm just simply out. And then I'll take my chances with, I'm winning, physician community's winning 90% of the cases, and they're winning at 3 to 4 to 5 to 6x of the initial payment. Now, it may take you 4 to 6 months, right? But some groups are saying, we're willing to wait. We're willing to wait just so we don't have our claims held up with the denial, the prior auth, the down codes, the prepayment. The other issue is the prepayment reviews, where they literally suspend your claims. They ask for the chart, and then they do, quote, medical record review. Nobody believes for a minute they're actually reviewing the records, but they ask for the records. So we submit the records, and they say, oh, well, it's going to take us 30 to 60 days to review the records before we can pay the claim. And now all of a sudden your accounts receivable have gone from 40 days to 90 days or 120 days. And so you're waiting 3 months, 4 months. You can appreciate from a business perspective, you've got bills to pay day one. You've got payroll, you have benefits, you have expenses, malpractice, right? All of these costs that you have to pay every month. And meanwhile, your very best payers are now extended out 90 to 120 days. And so groups are saying, you know what? If we can't get them to be reasonable, then we'll just terminate the agreement. It's interesting. That also starts then a discussion eventually, I think, with the health plan. Well, why do they terminate us? Well, they terminated you because of your claim adjudication practices. Well, can we have a discussion with them? And we're starting to see the plans come back to the table now. And one of the things that the groups are saying is, unless we have protections for denials, down code, prepayment review, and prior auth, we're not contracting with you. And so it's completely changed the dynamic. The other thing that's completely changed the dynamic, Cy, is the transparency and coverage data. It started out in the first Trump administration. He just wrote, they wrote proposed rules to expand it. But what it is in simple terms is the health plans have to disclose their allowed amounts, their in-network allowed amounts, and their out-of-network allowed amounts by TIN, by tax ID number, by CPT, by geographic area. So I can look up and see exactly what your hospital's getting for any of your CPTs. I can look up any group in the country. And so what that's done is it's given us the market rates, right? So we can look at that data and say, okay, how is your group compared to the market rate? Well, hypothetically, your contract says 150% of Medicare, but the market is 250 of Medicare. So we go into the plan and say, look, we don't want to go out of network. We want fair rates, but we haven't had an increase, COLA, right? We haven't had a cost of living for 5, 7, 10 years. We want that, plus we want to be able to be within the market rate. And oftentimes the plan doesn't even return a phone call, won't respond to an email. Okay, if that again, you're in a position with the group to say, if that's their position, terminate the agreement and go into the NSA. And that's, uh, unfortunately, that's where we are. I think it's really changed the health plan dynamic with groups, and I think the private groups in particular, who have kind of been on their back heel for the last few years, and you can see the AMA and other studies that show the number of private groups really declining. I've seen this pendulum swing both ways. When I started out in this business 30 plus years ago, hospital employment was very popular. Then the pendulum started to swing back. Well, now I think the independent groups are having a resurgence because they're through this process that we just described, they're able to get fair rates either through the IDR process or getting the health plan back to the table to negotiate fair rates. And that's something that has not occurred in decades. So I think that's reinvigorating, frankly, a lot of private practices in ways that I don't think any of us really saw when we passed this law.
Definitely. And I think that's a good segue to talk about independent practice as well and the future outlook for it. I know that volume, the number of lives affected by a health system or, volume of procedures done or, claims submitted uh, builds that leveraging or negotiating power with these health plans, right?
Mhm.
That's why a lot of big hospital systems, health systems have that leveraging ability just because of the network of physicians they have,
That's right.
their provider base, right? Now, when you look at independent practice, not many are in that bucket, right? And so, how would you say this leveraging or negotiating ability has been shifting or transforming throughout the years? And what do you think a stable independent practice looks like in 2026?
Well, I think, as I mentioned, that transparency and coverage data that we have now really allows an independent group um, to know what the market is. So if the hospitals are negotiating substantially higher rates for the same CPTs, then they can make their case to the health plan, right? In terms of quality metrics, the recruiting practice of the group. What kind of docs are they recruiting and attracting to their group? Are they board certified, residency trained? Those types of attributes. And what kind of special training do they have in terms of trauma or specialty, in terms of, heart center, stroke center, those types of attributes. So I think there are a lot of things that individual groups can leverage that way and make their case. I think the plans have not appreciated as much that it's really in their interest to have independent groups as opposed to having, two or three monoliths in a state that employ 90% of the doctors. Um, but I don't know that they care, frankly. But I think they should, is my point. I think what independent practice looks like now is, continued declines in. We got a little bit of bump of Medicare this year, but it's going away after this year. Continued declines in Medicare, continued declines in Medicaid. So the cost shifting, what you recover from your what we call the BUCA payers, Blue Shield, United, Cigna, Aetna, right? What we recover from them has to cover not only the uncompensated piece over here, but the loss that you have in Medicare and Medicaid. So I think a lot of groups are looking at their contracts and saying, for the first time in many years, we're everything's on the table because we're for our radiology groups, they can't recruit enough doctors. The demand for radiology is through the roof. Um, for our anesthesia practices, huge demand for them as well. For our emergency medicine, we keep seeing increases in ED visit volume every year, X of COVID, of course. So the demand's there. in terms of and I'm in this cohort, 10,000 of us retiring at 65 or being eligible for Medicare at 65 every day, 10,000 plus. I mean, that's a seismic tidal wave in terms of impacts on the groups. But I think I'm bullish for the independent groups. I have to say, we had a tough couple of years, and I lived with it with them. But now that we're through that and the NSA is really functioning, I think we've got a way to leverage against it. And I think independent groups are, and I think my sense is from the doctors, they feel like the tide has turned. And that's not a sense that I've had in a long time.
Definitely very hopeful, just for someone like me, just starting out with my training as well. And as we come to a close of this episode, what's one thing young physicians or physicians in training need to understand about payers before they sign their first job?
Yeah. I would definitely say they should try to find a mentor if they can, who understands, basics of physician contracting, health plan contracting, reimbursement, access your specialty society resources. And some of this is going to be self-study. But there's an amazing amount of material, both on X, on LinkedIn, on YouTube, in terms of, free training, free guidance on documentation. So take an interest in it, and understand that what you're doing it's no different than acting as your own financial advisor. Should I buy Apple stock today? I'm not going to just throw money at it and forget it, right? I'm going to study it. I'm going to look at what the experts say about it. I'm going to look at their earnings. The very financial things that you're learning right now. How do you read a balance sheet? How do you read a P&L? You're going to look at all of that. Do the same when it comes to your own practice. And I would say, as far as your own individual contracts with your group, don't be penny wise and pound foolish. Get a good lawyer who knows something about health plan contracts and can help advise you, because it's silly to think that you're going to be able to know all that you need to know to protect yourself. There are things that are written in those contracts, and I see them all the time, that a non-lawyer is just not going to pick up on, in terms of the significance. Like, oh, well, it has a non-compete provision for 4 years, which any court in the land would probably strike down. Okay. But if you don't know that, you might say, and they say, well, it's a standard provision, Si, you should just sign it and be on your way. No, actually you shouldn't. And that's the kind of thing that you need good legal advice for. So don't, the smartest doctors I know lawyer up like crazy. And I'm not in private practice, so I can't advise, independent physicians. But if I were a young physician, I would want to find and ask a mentor, hey, are there 2 or 3 lawyers that you would recommend for me? Or go to your hospital's general counsel and say, hey, when I'm out in the big bad world and I'm negotiating a contract, either with my group or maybe I'm working part-time with another group as a 1099, who would you recommend?
Well, Ed, this was an amazing conversation. There's a lot I have to learn still, and I'm continuing to learn as I go through this. I'm going to put the stuff you added for the show notes as well for the audience. And thank you so much for finding the time to speak with me and give hope for us physicians as we go through our journey. And thank you for all you do.
All right. Thank you, Si. Enjoyed it. Take care.